Record on this computer. Good morning. Welcome to MED240 Pharmacology, Thursday morning, January 21, week 3. What is due this week are, of course, all week 2 items, which is discussion and discussion 2 and this quiz here. Like if you see a little check, that's a quiz. Now, what's this week? We're going to go through the lovely world of antibiotics and with some going to go through some the list of antibiotics. And again, as a reminder, what's important when you're looking at medications is you really should have a grasp on pretty much three to four things: the generic name, the brand name, also known as your proprietary name. It goes, and mechanism of action. And understanding the mechanism of action would hopefully lead you to knowing what the drug is. For example, we already learned Tylenol, which is the brand name, acetaminophen, which is the generic name, and its mechanism of action is it's an analgesic in the category of NSAID, which is non-steroidal anti-inflammatory drug. So analgesic means it's for pain, and it's a good anti-inflammatory. So it goes, if you could do that for every drug that you ever hear in this course and beyond, that is that's the best way to look at, what do I need to know about drugs in general. So antibiotics. Now, antibiotics is a funny thing because they kill against bio life. And the life that they're killing is a prokaryotic species called bacteria. So antibiotics are not good for funguses. They're not good for viruses. They only kill bacteria. So when you get a common cold, which 9 times out, the cold is caused by a virus, giving you an antibiotic is not a good idea, because we already know from anatomy and physiology that that our body is full of normal flora or normal bacteria, or what the layperson calls good bacteria, that's inside you, that are actually they're really important for things like production of vitamins, which are important cofactors and enzymes in your body system. So if I give you an antibiotic when you don't need one, it's going to kill things that we really shouldn't be killing. Okay, even if I give you an antibiotic where if you do have a bacterial infection, it's still going to have side effects related to that. It's going to kill things that it really shouldn't. So that's what it kills. It kills bacteria. And remember, just as a quick review of bacteria, there are some bacteria that are aerobic, some are anaerobic. There's different types based on their morphology or shape. You have cocci, right? Like streptococci, that's in your lungs. You have bacilli, right? Which look like rods. You have curved bacteria, and you have spirochetes that look like little spirals. Okay, so how do we know you have a bacterial infection? Well, we should be able to see it on a microscope. So wherever sample we get, whether it be blood, sputum, or any other body fluid, we already know that one of the stains is gram stains. So this is also another categorization of different types of bacteria, which are gram positive and gram negative. And gram positive will, of course, absorb the gram stain, and that's why on the slide, it looks blue, and the gram-negative, which doesn't absorb the stain, and appears like pinkish. Okay. Anti-infectives, drugs that kill an infectious agent, and 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 the definition of infection is, remember, bacteria that's in the wrong place and in the wrong amount. Okay. And remember the example that we had from anatomy and physiology, Staphylococcus aureus. Your skin is full of it. There's tons of it, but that staph, if it goes inside your body, that's not a good thing, because it'll be the staph bacteria will be in the wrong place, and then if it grows inside your body, it'll be in the wrong number, and that becomes pathogenic, and that gives disease. So there's two. This is another categorization of antibiotics. There are antibiotics that they don't kill the pathogen, but it keeps the pathogen from dividing and or multiplying. And then there are others types of antibiotics that kill. So bactericidal, use your medical terminology powers, kills pathogens. Bacteriostatic controls the pathogen, the amount or its replication. So it'll still be there, but it doesn't make it, it disallows the bacteria to spread. Now, you may have heard this as well. Spectrum of activity, broad spectrum antibiotics versus narrow spectrum. Now, broad spectrum, that means it kills a whole bunch of different organisms. Narrow spectrum, it kills a specific one. And here are some examples. And the penicillins, which is ampicillin, amox, and the tetracyclines, those are the top three that are broad spectrum. So you'll hear a lot of that, and that's why when we do broad spectrum for prophylaxis. That's why we love giving amox before surgeries, that kind of thing. But narrow spectrums, that has it kills something. It goes specific, something specific. Now, remember I mentioned mechanism of action, MOA. Well, antibiotics like the penicillins and the cephalosporins, their MOA is they inhibit cell wall formation. So if your antibiotic has a whole bunch of holes in its cell wall, then everything on the outside will go in, everything on the inside will go out, and then that will kill the bacteria. Disruption of the cell membrane, right? Are cyclic lipopeptides. Lipo, remember, meaning fat. Peptide, which is a part of the building block of a protein. Some block protein formation, macrolides, tetracyclines, aminoglycosides. The quinolones are really good at blocking bacterial DNA. Metronidazole disrupts the DNA structure, kind of breaks it down. And folic acid is one of the many vitamins or cofactors that are very important in bacterial and even human processes. So that that category belongs to the sulfa drugs, commonly known as, the sulfonamides, commonly known as sulfa drugs. So here you have already examples. These are all generics that have their MOAs. So when you're studying, you could put the penicillins and cephalosporins in one, put these in another category. So wouldn't this be a beautiful both A and B question? Here, right? And a beautiful question regarding MOA of common antibiotics. Now, there's side effects. And most antibiotics have to be taken on an empty stomach. And the function is faster absorption. It's nice to know the exceptions, but another reason why you should take it on an empty stomach is because remember I just mentioned that bacteria, there's a lot of bacteria inside you, and the classic example is E. coli, and E. coli has a lot to do with the processes in your GI tract. Well, remember this thing right here, the spectrum of activity, especially if I give you a broad spectrum antibiotic, it's like shotgun therapy. For those of you who don't know much about guns, a shotgun typically shoots a whole bunch of pellets in a wide dispersal pattern. That means if I'm aiming at something specific, there's going to be a whole bunch of collateral damage. And the most common collateral damage is your gastrointestinal tract and are the antibiotics that are in the gastrointestinal tract. That's why when you take antibiotics, one of the biggest side effects is GI discomfort. And GI discomfort is a nice way of saying that your gut's gonna hurt and you're gonna have the runs. You're gonna have a significant amount of diarrhea. And remember, diarrhea for the very young and for the very old is not a good thing because it may lead to significant dehydration, and especially in the very old, the very young, lead to death. That's how serious dehydration could be. And that's why internal medicine in the world that I am from, we take giving antibiotics very, very serious. But again, there's good doctors and there are bad doctors, and there's some they dispense antibiotics like it's candy. And a classic example, which leads us to antimicrobial resistance, is remember the patient I told you about that has a virus, right? It goes, if I have a virus, I should give an antiviral. But if you have a common cold, if you're relatively, your immune system is relatively intact, if you have a common cold, which by the way is part of the Coronaviridae family, if you have a common cold, it's self-limiting. It should go away in 7 to 10 days if you just take a day or two off and drink plenty of fluids and get some rest and get some sleep and recover. But when a patient comes to your office and they plop down whatever $55, $60 on a $20 copay, they're going to want to leave the office with something. And this is what I learned the very first week I was a resident. You need repeat customers, and medicine is a business. So there are doctors that give in, right? And I'll admit, after a year, I gave in. And you give your patient something even though they don't need it. And also many patients always have this idea that, hey, I have a cold and cough, and my friend Susan had a cold, and you gave her ampicillin last week, and she got better like in a day. So all they see is the cause and effect. They don't see, and they don't have this training, and they don't understand that that's a virus. If I give you an antibiotic, it's going to start killing things that it shouldn't be killing things. And especially a broad spectrum antibiotic, because that's shotgun therapy, it's going to have a wide dispersal of what it kills, just like a shotgun. And it's going to do this. It's going to develop antimicrobial resistance. So let's say I give you an antibiotic, right, when you didn't really need it due to overuse and misuse. What's going to happen the second time around? You're going to have super infection because the bacteria that lived, it's going to learn. It's going to get smart and say, hey, you know what? You used a mox before, so I'm going to get really stronger, and I'm going to wear a bulletproof vest. So this next time that you get sick and it's bacterial, it's going to be stronger. Hence the term super infection. And then if I really need to use that antibiotic again, it's not going to work. A classic example is tetracycline. In the 60s and 70s, tetracycline had like something like a 90% efficacy, meaning to say is 90% of the time it would work on bacterial infections. Nowadays, it's down to like 32. Why? Because on the course of 4 or 5 decades, what did we do? We give tetracycline for everything, right? And we give amox for everything. So now you have this bacteria that's used to it, and now that drug is not as useful as it was in the past. That's why me personally, I don't take medication unless I really, really have to. Okay. And here's the classifications. We were introduced to some of them already. Sulfa drugs, penicillin, cephalosporins. We were introduced to some of these already regarding the MOAs, the little samples that we have regarding the mechanism of action. So now we're gonna jump right into the classifications. So sulfonamides, right? It is a bacteriostatic medication, and it's there's a broad range. And what do? They block folic acid, as mentioned earlier. And remember, folic acid or B9, it's a vitamin, it's a cofactor, and we already know from anatomy and physiology that, excuse me, cofactors are very important with enzyme activity and metabolic pathways. So if I block a vitamin, it's going to give the bacteria trouble, but it won't kill it. So that's why it's bacteriostatic. The most common one here is Bactrim. You've heard of Bactrim. That's sulfamoxazole, trimethorphan, right? Or cotrimox, cotrimoxazole, Bactrim, very, very common. Okay, that's number one most common. These other ones, I use them, but cotrimox, very, very important. And when you see combos, remember we talked about synergy, that term we talked about in the first lecture. It's when two parts of the drug help each other, okay? And cotrimox, Bactrim, they do that, and it's part of the sulfonamides, also known as the sulfa drugs. Now, nice thing to know is backup drug. What if my patient is allergic to sulfa drugs? Then we can give nitrofurantoin. Now, you are part of a lovely generation that has electronic medical records. So in a typical EMR, if you write down that this is the drug that you're going to give them, it'll give you all scripts will give you generic versus proprietary. It'll give you alternatives and even alternative dosages. It's really, really neat. That's if you have electronic medical records. If not, well, you do a lot of memorizing, and it's really good for now. Again, these things nice to know. Okay, what are they used for? Okay, again, a broad spectrum of things, and this is really nice to know. Cotrimox for pneumocystis carinii pneumonia, which is your HIV/AIDS patient. And again, what is the most common side effect for sulfa drugs? It's GI, what they call GI effects, NVD, which is nausea, vomiting, and diarrhea. Photosensitivity, and know that a lot of these drugs do a number and give the patient several types of anemia. Now, here's a nice little side note. Stevens-Johnson syndrome, which could be a nice trivia question. Stevens-Johnson syndrome is a severe allergic reaction to medication, okay? And it is probably the only listed emergency for the Department of Dermatology, okay? So it gives this severe rash, and it's a rarity, okay? But most common GI side effects, photosensitivity, and it's used for a whole bunch of things. But the really important thing is, what is its MOA? Its mechanism of action, that it's bacteriostatic. It blocks bacteria. It blocks the bacteria from making folic acid. Special considerations. Now, the term photosensitivity, what does that mean? If the patient is exposed to sun, there can be some some side effects, rashes and other things. And here's a nice term that you might see here. And also, by the way, these labels, these labels will be on the side of the bottle. So don't just give the bottle of medication to your patient. Make sure that they see and they can read um, uh, uh, the warning labels, because again, especially for polypharmacy, if your patient has a lot of drugs, how can they possibly remember all the things they should avoid? Now, this term right here, disulfiram. Now, disulfiram is a drug that's used for alcoholics. If you take if you take disulfiram with alcohol, ETOH is ethanol, also known as the good tasting alcohol like bourbon, tequila, just to name a few. Well, you're gonna start vomiting a lot. And we use the drug disulfiram to give like a negative experience to the alcoholic, so that they won't touch alcohol. Okay, but the thing is, there are drugs like sulfa drugs that may cause disulfiram effects. So the generalized rule for all medications is you really shouldn't take them with alcohol. Okay, because it may have disulfiram effects. You're going to have flushing, meaning they're going to get like beet red. But the big one is they're going to have this really nasty nausea and vomiting. Okay. So contraindications, precautions, and interactions, nice to know. But it makes sense that if I now know what side effects, especially photosensitivity, then I know now that, hey, what I should be aware of regarding precautions. Again, nice to know here. Remember, the person who created this slide is Dr. Cisco. She is a master pharmacologist, so she's going to have things in her slide. But this, for you future nurses, you're going to need to memorize these things. They come in 80 and 160 milligram tabs, and they come and things. Again, Stephen Johnson's, take with water. And for future nursing, when you're in your pharmacology 2, you're going to need to know all of this: contraindications, precautions, interactions, and dosing. And can you give it to children? But for this class, pharmacology 1, the stuff that I highlighted, those are neat. So that's what's neat about these particular lectures. You can actually use them again for those of you who plan to move on and plan to take pharmacology 2, the sequel to this class. Now, penicillins. Penicillins are really neat, and we already learned that their MOA is they mess with the bacterial cell wall. The neat thing about most penicillins is that they're relatively low toxicity. Okay. Now, here's another category of antibiotics, are the beta-lactam antibiotics. They mess with beta-lactamase, which is ACE. If you look at that last, the suffix, it is an enzyme, right? So that enzyme messes with beta-lactamase, and since it's low toxicity, it's one of the first penicillin, it's one of the first antibiotics that were out there in the world. So there have been a significant amount of abuse. So some bacteria have resistance because they produce this beta-lactamase enzyme. And this is a classic example how a living thing like a bacteria adjusts to its environment of being attacked by an antibiotic. Okay. We still use it, okay, but and the penicillin drugs, you could see the suffix cillin, right? And here's some combos, and the most common, the one that you really should know, is amoxicillin, clavulinic acid, or clavulinate, if you could say that 10 times fast. But we call it Augmentin. It's very, very common, and this combo is very, very effective. Again, it goes. You could try to memorize all of these, but the best thing to do is, they're penicillin drugs are part of the penicillin family, so you'll see that psyllin suffix there. But amox with clavulinic acid, that's Augmentin. This is nice, and that's a most common penicillin combo. Drug resistance, we already talked about that. And penicillin, again, wide form of stuff. We use it for prophylaxis because remember I mentioned amox. We use it for dental, oral, STDs, you name it. And you could see, since it has a wide array of therapeutic uses, you could see how over the last 50, 60 years, how it pretty much got abused. Now, here's the thing, the big precaution, and that's why we take good histories. A decent amount of patients are allergic, up to 10%. Okay, and again, most common GI, right? And then you have some rare ones, but know the most common first is GI side effects. Okay. Back to empty stomach, right? So it can get absorbed faster, and of course for the reason that I mentioned earlier. Okay. And again, drinking medication with things that other than water, not a good idea, because penicillins have been known to, like if you drink it with orange juice or soda, is not a good idea. And actually, soda is a diuretic. So, and also the other liquid, beer. I used to have patients who they pretty much live on soda, and it's sad because that was me in a recent past life, and it'll mess with your meds. Okay. Gram positive, gram negative. Nice to know. But again, like I stated, penicillin is broad spectrum. They work on gram positive, gram negative, and a whole bunch of different types. And contraindication, of course, if you're allergic to it, don't take it. Let's look at amox, broad spectrum. This is what it looks like. It could come in different kind of things, but let's say, for example, this is a question where I'm asking you to read the label. So this particular label, it comes in an oral suspension, right? And remember, suspension, and there should be a sticker here that says that, you know, you have to mix well before giving. And when you give it, it's 250 milligrams per 5 cc's. So if I ask to dispense 500 milligrams, then of course you have to give the patient 10 cc's, and it's oral, okay, for this particular suspension. And again, don't need to know the dosing for this particular class, but this is nice. These are nice slides because it's very, very complete, and it's just as good as any textbook. And when you see suspension, the big thing is shake well, because remember, the suspension has got little bits and pieces floating around in it. Now, let's talk about this, MRSA. Methicillin-resistant Staphylococcus aureus. MRSA is now super common, okay? We still use methicillin as a frontline drug for staph infection. But if you develop MRSA, right, then we have to give you the backup drug for MRSA is vancomycin. And if you're resistant to vancomycin, then you get Versa, which is vancomycin resistant Staphylococcus aureus. And if you have Versa, we'll talk about that. We'll talk about that later. But we give you, gee, my mind is drawing a blank. Ugh, that's killing me. But know that MRSA, methicillin resistant Staphylococcus aureus, that means a lot of the frontline penicillins won't work. So we have to give Vanco, which is vancomycin. Okay, another category is your cephalosporins, and they come in different generations, first, second, and third. And for this class, don't have to memorize, but kind of be familiar with these names. Now, because over the years we've developed even up to 5th generation, okay, and it goes the 1st generation, 2nd generation, they're better for gram positive. And when you get closer to the 3rd, 4th generation, they're better for gram negative, right? And you've seen a lot of these before that are really common. Keflex, woo, Cephalexin, give Keflex like it's chiclets. Rosafin, because I haven't practiced in close to a decade, so I didn't touch these 4th and 5th generations, but used a lot of 1st and 2nd generation. Ceftin, Cefzil, Seclor. Oh, Seclor is very popular. Okay, so if I mention the drug, I will say that if it's 1st, 2nd, or 3rd generation, and if it's 3rd generation, better for gram negative. 1st generation, better for gram positive in general. Okay. Now, Keflex is really, really common, and we love them for respiratory. Okay. And you may goes Keflex and Duracef, really, really common. Cephalexin and Cephadroxil. Okay. And these were the, and it's nice that Dr. Cisco put these in there. Nice little pictures, so you know. 2nd gen, right? What do we like using them for? For a broad spectrum of things. And again, the closer we get to 3rd and 4th generation, remember this chart, we like it for more gram negative things. 3rd generation, what's really common, Suprax and Vantin. And they also come in IV or parenteral form. Parenteral is, like intravenous, intramuscular, intradermal, but ceftriaxone, IV, Rosafin, very, very effective. Okay, and we use it for a lot of lower respiratory tract infections. That's what I use Rosafin for. Adverse, again, you can't go wrong so far in this lecture by answering nausea, vomiting, and diarrhea with abdominal cramping and abdominal pain. Now, now this says all cephalosporins look alike when written in generic form. Every drug looks alike. It goes if you're not familiar with it. But again, if you have electronic medical records, it's really neat. You just type it in there, and it'll give you like summaries like what you see here. And again, this is one of the drugs that we like to put in the refrigerator, and don't put them all the way in the back of the refrigerator because especially if you have a full-size refrigerator in your facility, it may tend to freeze your medication. Me, when I was working as a medical assistant, I love putting stuff in the door of the refrigerator and towards the front. And again, shake well if there's an oral suspension. Okay, drugs related to penicillin and cephalosporin. Nice to know. Carbapenems, again, part of the broad spectrum beta-lactam antibiotics. So we use carbapenems for antibiotics that as a beta-lactam antibiotic, and they have highly resistant beta-lactamase strains, as we already talked about. Nice to know, carbapenem, but must know, tetracycline. This is a broad spectrum bacteriostatic antibiotic. Okay, it's very, very good for STDs, especially the most common STD, which is chlamydia. So link tetracycline, sexually transmitted disease, think STD, think chlamydia. Again, common side effect is GI effects. But here, look at this, tinnitus, kind of rare, but tinnitus is ringing in your ears. It's also because it's part of the penicillin family, it's photosensitive. And for any medication, we got to be really, really careful with pregnant women and children. They run a different set of rules because pregnant women and children have different types of gastrointestinal motilities and also different types of first pass effects with their liver, right? It could do a number on them. It could give some adverse side effects that we don't like. Now, Tygasil, nice to know, right? Used for lower respiratory tract infections. It's similar to tetracycline, but even though tetracycline has a low efficacy, we still use it as a frontline drug, and Tygasil is the backup. Next, let's talk about the macrolides, ketolides, and quinolones. So, what do the macrolides do? They inhibit protein synthesis, and they're very good at pulmonary infections. And these two, zithromycin, azithromycin, and Biaxin, right? Zithromycin, also known as the Z-Pak, and clarithromycin, erythromycin. You could see the suffix mycin, so you're going to start thinking what? Mycin, macrolide, okay? Again, this is also a very good drug for, this is a more effective drug actually for chlamydia, but old schoolers such as myself would try around the tetracycline. Yeah, Z-Pak is also good. It's quick. They come in a 3-day form too, which is neat. Legionnaire's disease, a little bit a rarity. That is a lower respiratory tract infection, secondary to, you could get it from, if you don't clean out your air conditioning system, and it's good for the pneumonias. Again, empty stomach. Let's look at the ketolides, Ketek, telithromycin. Now, what do? Okay, they're like a macrolide, and remember the ribosomes, they make protein. So ketolides block protein synthesis, right? Just like macrolides. That's why we're talking about that in the same vein, in the same part of the lecture, right? So doesn't that look like a beautiful both A and B question? Hint, hint. Quinolones. If you see that, oxycin, quinolones, right? Quinolones, potato, same thing, right? But if you have oxycin, right? Cipro, very, very common, right? And it's, again, good for both gram-negative, gram-positive. And we like using it. I don't use it for STDs and UTIs as much. And it's good for GI stuff like infectious bacteria, And yeah, I've used it for URTI or upper respiratory tract infections. Versus if I take a macrolide, I like it for more serious stuff like pneumonia, like lower respiratory tract infections. Side effects, of course. Now, this is not too common, but it does happen. I want you to think not only GI with the quinolones, look out for joint and for this random inflammation like joint swelling. And it says unpleasant taste. All of it is unpleasant. So whoever took an antibiotic said, "This is tasty." They're not tasty. A lot of it's bitter, and it's just not fun. Okay. Its contraindication is theophylline. Just a nice side note, right? And acids interfere with absorption. And again, look at this. If you see this label, right, that means it has some phototoxicity, which is something to consider. And don't take with antacids. Synarcid, quinaprisin, dalforprisin. Another synergy combo drug, right? Now, if my patient can't take Vanco due to Versa, right, I can give them Synarcid, right? And again, all the drugs in this particular section of this lecture inhibit protein synthesis. If the bacteria can't make proteins, it won't live. Okay. Aminoglycosides, serious infections, right? Amikacin, gentamicin, two most common, right? And again, mechanism of action, the blockage of protein synthesis. Now, the big thing about aminoglycosides is this. They are nephrotoxic and autotoxic. That means you're going to have kidney side effects and hearing and balance side effects, okay? And minor neuromuscular blockade, but these first two are serious. So aminoglycosides, right? The two major side effects, which is a both beautiful A and B question, is nephrotoxicity and autotoxicity. So I could ask you, what's nephrotoxicity? It'll mess with your kidneys. So if my patient has a kidney problem, I really should not give them aminoglycosides. If they're an older patient and maybe their kidney enzymes aren't optimal, not a good idea to give aminoglycosides. And of course, autotoxicity, especially if it's an older patient with a fall risk, and then you want to give them equilibrium problems, yeah, sure, give them aminoglycosides. See you in court after that. Okay, so because we got to be aware of dosing with aminoglycosides because of these two major side effects. The next is cyclic lipopeptides. Now, they bind to bacterial membranes. Now, how can I remember that? Lipopeptides. Remember the bacterial and also the animal, prokaryote and eukaryote cell walls are made out of what? Lipids, and they have little proteins on it, which are peptides. So it makes sense that it will bind to the bacterial membrane. Now, it goes, what will it do to that bacterial membrane? It's gonna depolarize the membrane. Meaning to say is, remember we talked about in anatomy and physiology where the bilipid layer kept the water on, like, had a hydrophobic and hydrophilic section. Well, I attach a cyclic lipopeptide onto it, and it's going to disrupt it, okay, and the cell wall. If it disrupts the cell wall, you can no longer do DNA and RNA synthesis. So this is a tricky thing, right? Yes, it attaches to the cell wall, but its mechanism of action is leads to DNA and RNA synthesis. So think bacterial attaches onto bacterial cell wall and then messes with it, and then This is the eventuality. And the neat thing about cyclic lipopeptides is that they are bactericidal. They kill things, and you shouldn't take them with statin drugs. Statin drugs are drugs we use to for blood pressure and hyperlipidemia, right? And so it's very, very common. So we have to think about that before giving that. Now, linolazid, Vanco. Okay, remember Versa? We talked about there was an alternative for Versa. Where was it? Sinercid. The other alternative for Vanco, right? If I have Versa, is Zyvox, linolazid. Okay, so if I have methicillin-resistant typical Staphylococcus aureus infection, I first give methicillin. If methicillin doesn't work, that means my patient has MRSA. Because if my patient has MRSA, I have to give vancomycin. Now, because if my patient doesn't respond well to vancomycin and develops a resistance, that's vancomycin resistant Staphylococcus aureus, known as Versa. I could try Sinercid, or I could give Zyvox, which is linolazid. Okay, so know the alternatives to Vanco. Okay, because this too is now common. When I was practicing, we got really excited at Versa. Nowadays, it's called Tuesday. It's all over the place. Clindamycin, another broad spectrum antibiotic. And the thing here is it could cause severe dehydration. So if your patient starts having diarrhea, we discontinue it immediately. Nice side note, linolazid is very light sensitive. So, you know, you really shouldn't put it in anywhere where UV radiation, sunlight can get to it. Metronidazole, Flagella, really common drug. Now, this drug, it's good with bacteria, but it's also an antifungal and antiprotozoal, right? So it's really, it goes, we use Flagella a lot for fungal infections, and that's metronidazole. And we also use it for parasitic infections like protozoa. Okay, so this is how I always remember it. P, parasitic, protozoa, flagell, right? Flagell, fungi, fungus, mycotics, metronidazole. You see how just like your, what do you call that? Your concept map? There's a concept map that I've had in my head for 20 plus years regarding metronidazole and Flagell, and that helps me remember. So whatever way that you have to remember things, and visually, you could also use it auditory, like I just did now with, you know, the beginning letters of drugs and things of that matter. Nubupen, Pentam, nice to know. It's a second-line drug for pneumocystis carinii. Oh, by the way, you're taking a second-line drug for pneumocystis carinii pneumonia. Don't make any plans. You're not going anywhere. Call it a day. Once we start using second-line medications for second and third-line medications for an AIDS patient, it's usually at end stage. Ophthalmic antibiotics, otic forms, meaning that I got to put it in the patient's eye. And just know that it's highly irritable to the patient's eye. I can't remember my ophthalmology, but almost every medication that I put in my patient's eye, they always complain like, it burns. So that is the basic lecture for the antibiotics. And you could see how we kind of like, Dr. Cisco tried to make it comprehensive, but she chopped it up. So the best way to study it is in sections. What I used to do when I first took pharmacology, I had like different color like flashcards for the different categories so that I can remember. And remember the most common drugs. Those are the ones that that we like. So here's a nice listing of antimicrobial agents. Oh, looky here. Oh, look at this. Don't you think I could find a list like this and then make a flashcard and just print this out and cut and paste it on the flashcard? Yeah, I could, right? So this is nice. Let me see. Yeah, it's a little bit on the specific side. I like the lecture better. Let's see, Cliff Notes, antibiotics. Oh, Cliff Notes are wonderful. It got me through English Lit in undergraduate. So these are some more notes, more nice things, but I really like Dr. Cisco's lecture here. It's quite comprehensive. And basic information on the classes of antibiotics, another website. Well, this is cute, right? This is also another way to, you know, you can print it all out and then, you know, make a flashcard out of it. It's one way to do it. So let's look at the discussion which is due for next week. And of course, hit up the quiz, utilize all your powers and take your time. So let's look at discussion 3. So superbugs that have minimal treatment options because these bacteria have been significantly abused. Therefore, they have massive amount of resistant to antibiotics. And we already talked about how, you know, abuse and why. Now, why do you think it's important as healthcare professionals to help, use the word ameliorate, like how to deal with this situation? That's a fancy word. So find a protocol in your typical clinic or typical hospital, and of course, cite your source. And try to find something from, like, you know, the last couple of years. How do we deal with superbugs? How do we deal with resistant strains to common antibiotics? Okay, and find a protocol on how the hospital does it. That's you know, pretty straightforward. What I believe is the path you should be on. Now, going into next week will be we're going to talk about AIDS and HIV, right? Because that's really important. Antivirals and antifungals. So this week was antibiotics, which only deal with bacteria, right, for the most part. But next week is antifungals and antivirals. Antifungals, of course, they deal with mycotic infections, fungus, and antivirals deal with viruses. And this is very apropos to what's going on now. And we'll also be talking about why it's really hard to kill a virus. Well, right off the bat, a little preview. Viruses, if you recall, they're tiny. They're very, very small. So it's hard to, and then they go inside the cell. It's hard to fight something that incorporates into your own DNA, and I'm giving too much of the show away for next week. So it is this portion of the show where I will